this your?
No, I'm at work.
Okay, perfect.
I'm at work.
Good. Me too. So how you keeping?
Yeah, not too bad.
Good.
Not too bad.
Good.
A lot going on, as you might imagine.
Yeah, I've heard one or two bits of so good stuff. Okay,
Yeah.
Are you happy to get stuck in?
Yeah, of course.
Okay, wonderful. All right, so ladies and gentlemen, good afternoon. Professor Dave Jones, OBE, good afternoon. I've not seen you for ages, at least not till the summit, which I'm sure will come up.
That's because Mo does it. Mo does it. Can I just say, I don't know if you've watched any of this. She does it in a different way. More,
you can say better. It's okay.
Yeah, more. I'm slightly scared of her, actually, to be honest. So, but there's nobody listening, so nobody will hear that.
That's two of us. No, it's all good. It's all good. So, no, I actually, and it was the same with Colette. Colette did it a different way as well.
Yeah.
And I think it's as good for the people that are here, and those of you that are in the room, come and tell us about this if we're right or wrong. But to hear the different presentation styles is as important.
Yes.
Hearing the different doctors.
I completely agree with that, and I think the format, the mix of different doctors, etc., different presenters, different chairs of it all. It just gives you a different vibe and a different. And I've said all the way through is that this is, of course, educational. Of course it is. That's why we do it. Oh,
5 years.
5 years, yeah. So, of course, this is educational, but it's also, I want to entertain people. I want people to think, oh, that's going to be good, and there's nothing worse than a really sort of boring and stilted thing that people feel that it's participatory. So It's serious purpose, this. It's deadly serious, but actually it's, I just think that I think it, and other people will work in a different way, and other people would like a much more formal way of doing things, but I think it's just different. I think it is one of the strengths that we have, so many people on both sides of the kind of camera, if you like, that we can mix it up and do it in different ways. And so I think that's the strength of the model.
Perfect. No, that's great. So before we get stuck into questions, I'm just going to say, so firstly, good afternoon, good morning, good evening, wherever you are in the world. Delighted you're here with us. So as ever, we're not here to give you specific medical advice. We're here to give you general medical information. And we're certainly not here to take the place of your appointment with a consultant, but hopefully trying to empower you and inform to improve your next appointment with your consultant. Anything I missed out from the preamble, Dave?
No, that's all right. I mean, and remember, I say this always, but we do use people's experiences and their questions too as a canvas to paint a picture, if you like. So we tend to generalize the questions that people ask about their own experience so that it becomes potentially relevant to other people. And some aspects of that aren't going to be. So somebody might ask a question about transplant, and that's not going to impact, practically speaking, on most people. But we will always try and contextualize it.
No, perfect.
And I think we get the balance about right, actually.
Yeah, we try. All right, thank you. So, Professor David Jones, OBE. My first question for you today is actually, so obviously we've come home from the summit. We've got a whole lot of takeaways.
Yeah.
But as the chair of the Medical Advisory Board, what would you say to the patients who are watching how you experience the summit, what we as the foundation do at the summit, and how those incredible 4 or 5 days of hard work benefit the patient community?
Yeah, so I think the first thing to say about it, it's not like anything else. I mean, it's not like anything else in terms of its ethos and its approach, and it's the way it gets people together is not like anything else. And actually, I think this is in the organisation and the sort of spirit of it. It evens out. There are no power hierarchies there, which I think is very important. I think medics can slip into the do what I tell you to do sort of mindsets, not in our world particularly, but it's a danger. I think it evens it all out, which I think is the first thing. I think the second thing about it is and I know this from the industry colleagues, and I do talk about industry colleagues very deliberately because they are really important in our mission, because fundamentally developing and taking to market a drug is an expensive business that only companies can support. And so sometimes in our world, you get people who are anti-industry. Well, that's being anti-having treatments. And right from the very beginning of the journey with PBC, we've been very clear we want to work with industry, but we also want to work in a way that is the right way for patients. So we set the terms, and in return for that, they get unparalleled kind of support and access and things like that. But they don't dictate terms, we collectively do. What I do hear from our colleagues in industry, and we are very lucky, we have very good companies with very good people involved in this, is that they get a type of communication and interaction that they have never encountered in any other setting. So I've heard that so many times, is that this ability to really just come and air any thoughts and any questions and any ideas, and actually, put together a little conversation, has anybody on the eye about this? Oh, well, that person over there does. And it's just not like anything else. And so they find that very valuable. And I do know it energizes them because their job is tough, going through the regulatory process. It's a grind at times. And actually they get re-energized by, it's a reminder why they do what they do. So this idea that industry in it for money, they're not. They're professionals like we all are. I don't do what I do for the money, and it's nice to have a house, but that isn't the motivator. And I think it's the same for the industry colleagues, is that it makes them really feel they're part of something, and that they feel the success of people moving down and having therapies and things like that. So I think it's unique. And I think it gives us, as a sort of road test, to what you will have noticed, or what people will have noticed, is a sort of a road testing of concepts and ideas. So it's almost workshopping, that you put an idea out there and we see what the level of interest and excitement and so on is with it. So I think you see some of that. I think one of the trends from all of this is around that those people who are there will have been, aware of the clinician global impact scale work with Umacrine that the foundation has driven forward. I think that's the first time it's really been taken public, if you like, outside the people involved in it. And that's really captured this idea that we can, in a sense, quantify somebody's experience. And I know that sounds trivializing, that your experience is your experience. But if we are going to get drugs, we have to be able to show that those drugs work. Otherwise, we're not going to be allowed to use them. Yeah. And so developing the tools to show that they work is a really important part of this. To make money in a gold rush, you need to have a shovel as well as a gold seam, if you like. So that side is very important. I think people were very taken by that. I think that message then goes away. I think what in a sense, the first day when everybody sort of breaks out into their own little sort of groupings, I think what you didn't see was, once again, the sort of uniformity of view of the medical advisors, and the sort of the consistency of the viewpoint of the people who are there. And I think we as I shall let you into a little secret, is not all academics get on with other academics. They're famous for knocking lumps out of each other. And the history of PBC, actually, in the bad old days, was quite a lot of that. And one of the things that we all tried to do, more recently, is to get away from all of that. And I think the consistency of the view, everyone, there are nuances, experiences are slightly different. Countries have different healthcare systems. All of those things are different, but the core belief set based on evidence is the same. I think that consistency of the viewpoint is very important, and with the patients in terms of what matters. What are the big themes coming forward? Symptoms, and that, to me, as people will know, I have been with the foundation really plugging away at that for years, with people thinking it's not important. And now you all thought it was important. I thought it was important. It's just that many doctors appear to sort of shut their ears. And we've now cracked that in terms of people seeing the importance, both clinicians, but also companies and regulators. And, a shout out for GSK in particular. Obviously different to many of the companies that we work with, but they've done a phenomenal amount of work in supporting the trial design. How do you do an itch trial? It's really hard work. What is in an itch score, what improvement in the itch score is enough for a regulator to approve a drug? It's not exciting science. It's not going to change the world, but it's the shovel again. And you have to do it. And they've done a phenomenal amount of work for the field that will actually benefit everybody in it. And that ultimately is patients. So I think it's important, they have done important work with us. So I think symptoms everyone's really serious about now. The big frontier is fatigue and brain fog. That's going to be the next big area. Some interesting things coming along with that. And then I think normalization, I think the move towards normalization of tests as the target is pretty much complete and is now accepted, I think. The only thing we need to just be cautious about the background to that is that, what level of alkaline phosphatase is acceptable. And before, in the bad old days, which is until a few weeks ago, really, a joke, but in the bad old days, we ended up convincing ourselves that there were certain magical values that as long as your alkaline phosphatase was below that, didn't matter if it was still abnormal, it was kind of okay. And there was a sort of group think about that, which it may surprise you to hear I never really bought into. But that got us drugs like Oca and elafibranor and seladelpar. So it got us the drugs. That's very important. But it was clearly a bit of a nonsense. And there was a lot of evidence from various different sources showing that there was still a risk. I mean, if gosh, who knew? If your blood tests were abnormal, there was still some risk. It was not as high as if the blood tests were really high, but there was still some risk. That's kind of predictable, but, we're academics and we sometimes don't see the nose in front of our face. So I think the acceptance of all of that. What we've got to be, so now there is a realization that the only way you get the risk as low as is possible to get it is by making a test normal. Okay. And I think we all agree with that. The evidence is there. The regulators, I think, are going to tie it with that. The only thing is a word of caution is that don't have a race to the bottom in terms of clinical trials. So an analogy I've used all the time recently is that if I could start the Olympic 100 meters final at the 90-meter point, even I could win it. Okay. Robert's doubting that, but I think I could actually, right? The point is that the closer you are to the finishing line, the easier it is to cross it. So therefore, if you want to have a trial that shows that 90% of your people normalize their blood tests with the drug, the easiest way to do that is to take people who've got minimally abnormal tests. Okay. Now that's important information. However, the big challenge is not the person, upper limit of normal is 130. The problem with PBC is not an alkaline phosphatase of 140. That will normalize with pretty much every therapy. And in a trial, that would show it was successful. The problem is 840. Okay. And that's where we need to go. So what we really also need to do is not just, I can normalize more people with my drug than you can normalize. We need to bear in mind that not everybody with an abnormal alk phos is the same. Yeah. And we need to make sure that we put the most focus on the people who are at the highest risk. So everybody matters, but it matters more over a short period of time in the younger people with very abnormal alkaline phosphatase. So we do need to make sure that we don't forget about that aspect. But that's the whole point of these exercises. You're never going to get it sorted out in one go, but you need to convince people about normalization, but then you need to just have that word of caution. Would you agree with that, Robert?
I do. I absolutely do. And I think it's fascinating to see the journey from the first summit, where there was quite, I think the professional term is robust conversation, robust exchange in and around this concept of normal being a target.
Yeah.
And, it's great to see the progress has been made in and around that. I remember you giving some thought as to, how do we hook what it is that we're going to be doing next in terms of those targets. And you said it's almost like we need a Project 1990. And then from those thoughts, we've got this incredible, program now that's going international. And again, GSK in their symposium at EASL are going to be presenting the Project 1990 concept to a wider audience. So, there's incredible things that are being done and changes are being made. It is slow, it is gradual, but it's absolutely going in the right direction. So, which is fab. So I just wanted to let people know, because we talk about it, but as a clinician, an academic, and who's somebody that comes in and sees what it was, I just thought it'd be important for you to share with our viewers actually, what the summit means to the community and why we do it the way we do it. So thank you. Okay, we're on to the quickfire round. So,
can I just add one thing? I studiously avoid politics in all of this. In general, doctors and politics don't mix. But governments come and governments go, and no government is a government without a restructuring of the health service and a 10-year plan to solve all the problems of the health service. It's par for the course. So we exist in a world, and this is for UK people, the challenges around healthcare systems are different in different countries. Just something for people to keep an eye out with is some of the talk around the 10-year plan. So we'll hear a lot about this in the UK, about the future of the health service. And one of the big focuses of this is for care to be delivered by GPs in the community rather than in hospitals. Now, the word of caution is that this assumes that GPs are competent and experienced and interested enough to be able to manage things where they have limited experience. And so we just as a community need to be cautious about that. We do know from the audit that even in hospitals without expertise, care can kind of drop off in terms of what you actually need. And I think who wouldn't love to pop to the GP and get all your management done at a time and a place that's convenient for you? However, that works in Whitehall. The reality for everybody is you can't get an appointment with the GP anyway, and they won't get involved in any aspect of all of this. And certainly one of the frustrations that we have is where people are sort of referred up to us for advice about how to manage itch, and we suggest using rifampicin, and the next thing you know, the GP will say, well, I'm not going to give rifampicin, I've never heard of using it for itch. Well, with all due respect, that's why you asked us for our opinion. And so I think we love the idea of more care. I think, in many aspects of life, the last place you want to be is in a hospital. But actually, if you're getting looked after something complicated, and this is quite complicated, you really do need to have the wisdom of people who know what they're talking about. That does not mean you have to see me or George Mells or Emma Culver or any of us, but it means that our knowledge needs to go out there. And I think that the interest for us, it's too easy to say GPs can do this. Without the information and the systems behind it, that isn't going to work. So it comes back to one of my favorite thoughts, and this is Project 1990, because having a system that is effective to get information across is the best way to hit those 90%, isn't it? Because it's the randomness of it that's the problem. And so it comes back to, a hobby horse of mine, which is the sat nav for PBC care, which is that we need to be able to have, and just imagine if you had on your smartphone or whatever, a pathway that guides your GP or your hospital consultant what to do when your tests are at X, Y, and Z. That could be run by the NHS, it could be run by the PBC Foundation, it could be run by anybody, but you can't just ask a GP to know what to do. That's a cop-out, really. So, if these things are being done in order to get better care and it's more convenient for people, that's fine. The motivation for a lot of this is saving money, and I think people should be honest about that. And actually, unfortunately, in our world, these are false economies. So if you get PBC right early on, then actually what you do is prevent having to spend a lot of money managing complications later on. So the money argument actually falls apart. But yes, you do spend more on drugs earlier in the disease, but you spend much less on transplants later on, let alone all of the illness that goes with it. So yes, but really cautious about all of this. But Robert's onto this, and the foundation's onto this. There is a way forward, but we need to do it for the right reasons and realise the issues that go with that.
Perfect. No, that's helpful. Okay, brilliant. Right, we've got a couple of questions. So, yeah, you said that you don't do politics. So, I'm in Northern Ireland. Are there any clinicians from there involved in the summit? So I can say no. And we're not really being overly successful in terms of really connecting with Northern Ireland and bringing people in. Is there anything you want to say about that?
Yeah, I mean, gosh, for somebody who the words Northern Ireland followed by I don't do politics is a complex one, isn't it?
Yeah.
So the landscape for PBC in Northern Ireland. So in general for liver disease, they haven't quite got the setup that you have in other parts of the UK. Okay, so there aren't the specialist interest centres. There isn't a transplant unit. So, for example, Belfast in particular has very good medicine, but like parts of England and Scotland and Wales, there are parts of the country which are better provided for by liver disease than others, and that's definitely true there. There are good people there; they're just not networked in. What I would say is that there is a big initiative going on at the moment around rare diseases. So PBC is a rare disease. That's a technical definition. 50 per 100,000 of the population is the cutoff for a rare disease. PBC is just rare. It's about 45 per 100,000. So it's a common rare disease. But being recognized as a rare disease is actually very important because it slightly alters the pathway to getting drugs approved. And it also alters the way in which care is delivered. And so there are national initiatives around how we do trials and things better in rare disease, but also deliver care better in rare disease. And PBC is our exemplar. Now, given that I run a number of those initiatives, it's no great surprise that PBC is prominent in it all. What I would say is a major focus of that is evening it up between the four nations. And in particular, the person who's leading that work for that consortium is a very bright professor from Belfast. She doesn't work in liver, but is absolutely committed to making sure that we don't have inequalities. So I will actually take that. She's in Queen's University in Belfast. So I'll actually take that back to her and just get her thoughts on the landscape and how we can knit in Northern Ireland better. So I will take that away. But it's early days and I think it's going very well. A couple of observations, one a positive one and one a less positive one. The positive one is that the island of Ireland is integrating its rare disease work a lot more. So there is a big initiative in the Republic and they're reaching out into Northern Ireland. So trying to get away from the sort of narrow border issues because I've got colleagues who, trained in our clinic who work in the Republic of Ireland. So there are good people in the Republic. So can we ease the way for them to be involved across the, this is not a political comment, right? This is about how people can get the best possible care, right? So there is a lot of thinking and work going on around that. The less good thing is that the whole issue about the ambiguous relationship of Northern Ireland to a post-Brexit UK and the EU is a real problem because even the people in Northern Ireland don't know whether they're under UK drug approval or European drug approval rules. Now, that's important because in the UK, we've still got access to obeticholic acid, whereas in the EU, they haven't. So it is a real mess, actually. It's a real mess. But I will take that away. It's a really good question. I've got very good colleagues really committed to integrating thinking and the cultural, links. How do we do that in practice? I mean, practically speaking, the flight from Belfast to Newcastle is 30 minutes.
Yeah.
So it's quicker to get from Belfast to Newcastle than it is from Newcastle to Leeds. So, I think it just needs a slightly different way of thinking. One of the things with devolution was that healthcare systems wanted to do everything themselves, and that's fine. But unfortunately, there are certain things where expertise is thinly spread out. And there are, we feel this in the northeast of England. There are things in Scotland that we would love to have access to for our patients, but we struggle with that. But that also applies in reverse, where there are aspects of what we do, particularly around the symptom stuff in PBC, where it is difficult. I hear from colleagues it's getting easier. We'll have to wait and see. But Northern Ireland, we are aware of. We will. It would be lovely if we could get somebody interested enough to become, suitable for the medical advisory board. I mean, it would be. I think it would, because we cover, in various different ways the rest of the UK. So I think that would be a good thing.
No, ideal. Perfect. Thank you. Okay, wonderful. Right, here's a question. There's this thing called PBC.
Yeah.
Now, if I have a AMA positive,
yeah,
alk phos is normal,
yeah,
gamma GT and ALT are raised,
yeah,
do I have PBC?
Okay, so the main question actually here is there sufficient concern about there being PBC to suggest that PBC treatment would be beneficial? Okay. Yep. So having a diagnosis is fine, but actually the real importance for diagnosis is it helps you get the right treatment. So when we think about these things, is there enough here to warrant treating with ursodeoxycholic acid, which is at the end of the day a very well tolerated, simple, straightforward treatment. So there's pretty much no downside to it. A little bit of sickliness sometimes, but there's no negative side to it, and it's also a cheap therapy. So the bar to use it for me is relatively low. Okay, so technically speaking, the definition of PBC is 2 out of the 3 criteria as follows. 1 is an elevated alkaline phosphatase. 2 is a biopsy with findings compatible with PBC. And the 3rd is AMA positive or one of the equivalent anti-nuclear antibodies. 2 out of those 3 makes the diagnosis of PBC. Okay. Now, technically speaking, the story you just said, you don't meet those criteria because you've got AMA, but you don't have elevated alkaline phosphatase. However, gamma GT is also a marker of the disease process in PBC, as can ALT be. So it's a technical not meeting of the criteria rather than you don't have normal liver blood tests. You just have a slightly different pattern to the conventional one with PBC. So what would I do if I saw you in my clinic? Well, I would explain all of that. Okay, I would explain all of that, and I would lay out the options to you. So one is wait and see. So if your alk phos is normal, it's not going to be a significant process. You've kind of met the criteria for treatment already. So there's probably not that much to be lost by watching and waiting, but you do need to make sure that somebody looks at the blood tests and actually acts on them. The worst case scenario, if you check every year, is that you're going to have a little bit, under a year's where the disease isn't treated. That's not a big deal. So that's a perfectly viable thing to do. The other argument is if it walks like a duck, has feathers and quacks, it's probably a duck. And, you're not treating on the basis of technicality. What is there to lose by giving somebody urso? And I think if it were me in that situation, I would take urso, because I would take urso and just forget about it because it's never going to become a problem. That logic also applies with symptoms, by the way. So we do occasionally see people who are AMA positive who their kind of other feature, if you like, is either itch or fatigue. And in those situations, I would regard that as converting AMA positivity into probably PBC, and I would talk about treatment with it. It's not crazy to take treatment. It's not crazy to not take treatment. It's a personal choice. Either way, the risk is very low, but I struggle with strongly suspecting somebody has a treatable illness and then not treating it. But I would literally lay out that argument, to people and help them make their decision. about 2/3 of people in my experience take treatment in that situation, about a third wait and see. But if you do wait and see, make sure that you don't fall into the trap that we see all too often, which is that you agree to wait and see, it gets checked the following year, somebody else sees you in clinic, discharges you from the clinic, and 5 years later you got cirrhosis. And I've seen it, right? Robert's seen it. So we just need to be aware of that. That's why being on treatment is probably a good reminder of what's going on. So I think you can play it either way. I'm in the pro-treatment camp.
All right, perfect. Thank you. Okay, we've got somebody who is 114 kilograms.
Yeah.
They've been on 500 milligrams twice daily for the last 12 years.
Yeah.
Their LFTs are normalized.
Yeah.
But their symptoms are getting more pronounced.
Yeah.
Is that linked to their URSO to any degree?
Again, it's a good question.
It's a
good question. So people will be aware, the mantra is 13 to 15 milligrams per kilogram. My beautiful assistant will now show you a calculator that allows you to calculate your. So, oh, Robert, I plug the calculator every single time. So the foundation had come up with nobody can do their 13 times table in their head. So the foundation have come up with a very good, simple calculator to work out what the optimal dose is for you based on your body weight. So it's really just very simple, because it's not, you don't keep these things in your head. Okay. The reason for a range of dosing is because, here we have it.
We have English and we have Spanish.
There you go. And it just helps you work out what the optimal dose is. Why do you have a range? Well, the answer is you need to find out a combination of tablets you can actually practically take. So confusingly, URSO tablets come in 150s, 300s, 250s and 500s. So you need, there's no point in having an optimal dose that you can't physically take. So I would tend to err on the higher side of 13 to 15 range if you've got a choice, rather than the lower side. Now, anybody who starts on URSO today should go on to the dose between 13 and 15 milligrams per kilogram that they can take easily based on the tablet dosing. There are some people out there who've been on a far lower dose than that for historic reasons. Now, a certain Professor J. Neuberger, whatever happened to him, who known in this parish, swore by 600 milligrams of URSO a day. Okay, and when URSO was first introduced, people did go for much lower doses, 600 milligrams, 900 milligrams. So there are people. There are people who were put on those doses in good faith at a time when we didn't understand the dose thing. Now, it's interesting, when I mentioned the audit, there was a national audit of PBC in the UK, which is a phenomenally important piece of work, because this isn't about what we should do, it's about what we are doing. And so, the road to hell is paved with good intentions. And so knowing what we would love to do is fine, but what we actually do is what matters. And this audit showed that there were a number of deficiencies in PBC management, and one of them was underdosing of URSO. However, there's a very important caveat, is that included people who were on, quotes, too low a dose of URSO, but in fact had responded fully to it and had normal blood tests. Now, there is no reason to increase the dose to get a better biochemical response if you've got a full biochemical response. So our policy is not to increase the dose of URSO in people who are responders, even if that dose is, quotes, too low. But you've thrown a wild card into this, which is that symptoms aren't controlled on that dose. Now, symptoms are relatively rarely improved by URSO, okay? So you can see some itch benefit. So the standard recommendation we make is not to rely on URSO for symptom treatment, to look at other ways of doing symptom management, particularly itch. But I would always put people on the right dose of URSO, not least because if you don't, somebody will come along and say you aren't the right dose of urso and that's why you've got symptoms. So in this situation, I would bump up the dose of urso to the 13 to 15 milligrams per kilogram, but I wouldn't necessarily expect it to normalize the symptoms. And so I'd want to review the symptoms afterwards. So in this situation, if you didn't have any symptoms, I'd leave well alone. If you do have symptoms, I think it's useful to optimize the dose, but be realistic about what will happen.
Okay, perfect. Thank you. And then similar to that is the symptoms and urso response.
Yeah.
So you know my question, but I'm not quite entirely sure. So I get, somebody's saying that the LT is slightly raised, but other than that, they're good, but they just have no energy.
Yeah.
So what can we tell them in patients like that in terms of looking at urso, the urso dose, the urso response, and then their actual symptom burden?
Yeah. Okay. So in general, there is no connection between the blood tests and symptom severity and PBC in general. There are one or two caveats to that. So people with a very high alkaline phosphatase levels often have more in the way of itch because they're more cholestatic. But there are people with good biochemistry and symptoms and no symptoms, and there are people with bad biochemistry and symptoms and no symptoms. And so it's one of those things that often puzzles doctors because they assume the symptoms must naturally improve if you improve the blood tests. And actually, that's a fallacy because, how bad the injury is, it is not necessarily, in any aspect of medicine, a predictor of the symptoms that come from it. Some of the worst chest pain that people get is from minimal arterial narrowing, and there are plenty of people who have no angina and then suddenly have a big heart attack, so blocked off a big artery. So how bad your artery disease is and how bad your angina is not connected. Anybody who's broken a finger will know it's just as painful as breaking a big bone, right? So it's not as much a surprise as people think it is. What it does do is lead to people entering into a false logic loop, which is because the blood tests are normal on treatment and they've still got symptoms, the symptoms can't be due to the PBC. Therefore, and then the sort of evil twin of that argument is therefore the symptoms are not for me as a hepatologist to manage, therefore somebody else to look after because it can't be the PBC. And that's not helpful to anybody because they are likely to be the PBC symptoms. And of course, they're still your problem if you've got the symptoms, even if the doctor has convinced themselves they're not their problem. So that logic is not helpful. It can't be the PBC because the blood tests are normal, and therefore if it's not the PBC, it's nothing to do with me, right? And I'm sure there'll be people on this call who've kind of had variations of that conversation over the years. So why therefore did I say you should optimize the treatment? Well, remember, if you're going from really first principles, there are two reasons why somebody with PBC might get fatigue, okay, no energy. Now, we spend a lot of time talking about PBC fatigue, okay, which is the sort of fatigue you can get with PBC of any severity. So it's just part of the disease and it's not linked to the blood tests, and it doesn't particularly improve with urso, as I've said. There is another sort of fatigue, which is much rarer, which is the fatigue that you get when you become cirrhotic. So cirrhosis, we don't talk about very much. Why? Because we don't see it very commonly. But people with cirrhosis, Marco Carboni, who many of you will know, did a lovely work with James Neuberger, a number of years ago, looking at people going through up to and through transplant, and showed that actually the worst symptoms in PBC were where people had a combination of PBC symptoms and cirrhosis symptoms. So actually not being cirrhotic is good for your long-term survival, but it's also good for your symptoms. So that's why treating the disease properly is the right thing to do, because that will at least ameliorate some future symptoms. But it does not mean just because you've got normal biochemistry, your fatigue is solved. You know that, I know that, but sometimes doctors don't know that. So what do? Well, you need to then approach the fatigue from first principles as we do. So we see in our clinic lots of people in a steady state. The average patient coming to our fatigue clinic has normal liver function tests on treatment. They've already been through treatment and still have symptoms. And so we have a very structured approach to it that looks at things that are contributing to it: thyroid dysfunction, anemia, nighttime itch. We have contributing factors, so low blood pressure when people stand up, underperfusing the muscles, sleep disturbance, depression can contribute, and then we go through lifestyle adaptations and coping strategies and things like that. So there is a very structured approach that you work through with fatigue. And actually what you do is usually find something that you can modify that will improve things and will give people enough space to be able to get back to a more normal life and be able to get things moving in the right direction. So it's a completely different approach. It's a different problem. It's a different challenge. It is the enemy of a good life as opposed to the enemy of a long life, of a short life, which is where abnormal biochemistry is. But you do need to just do it in its own specific way. So this is going to be the next big frontier in PBC, right? Now, all of this, you could call this a bit soft, couldn't you? You know, finding ways to cope and to live with it all. However, as I've said to every company and every researcher interested in fatigue, if I had a magic tablet for fatigue today, you would not feel any better with it, because your body is so used to not doing things that you actually will need to rehabilitate. So seriously, we will need to get people to build up their activity again, to go back from normal. If you'd broken your leg and were in a plaster in bed for 3 months, you wouldn't be able to walk. You go into space, you can't walk when you get back. So people become deconditioned very easily. So I warn people that the magic bullet isn't going to work, because you're going to need to have the magic bullet, but also rehabilitate people and getting them up and going and believing they can do things and having confidence in their ability to do things. So it is always going to be a much more complicated, slightly more time consuming process. So fatigue is fatigue, itch is itch, raised biochemistry is raised biochemistry. They're all important. They need different treatments.
Okay, perfect. Thank you. I've got it's general to the point of being vague, but it's an important question. So I'm going to ask it and let you tackle it. Recently referred to the liver clinic at the hospital as my blood markers have been abnormal for the last 3 tests. They took 9 different vials of blood, but I've been told that none of the tests led to a clear diagnosis. I've been waiting from a letter from the doctor to confirm next steps, but not knowing it is making me crazy.
Yeah. Okay.
How can we help?
So the 9 vials of blood is because there is a standard approach. We call it a full liver screen. So if all you know about somebody is their liver blood tests are abnormal, but you know nothing else about why, then there is a standard set of tests that we would do, and that's pretty much the same in every hospital. It looks for all of the common and treatable causes for liver disease. Okay, so don't read anything into the 9 vials of blood. That's just standard practice, and the tests are all done on different blood preserved in different ways. So that's the reason behind it. Yep. So they will have rechecked your liver blood test. That's standard. You'll be amazed how many people's bloods improve and normalize in between the time the GP does them and you go to the hospital. So they'll have repeated them, and they'll have done all these additional tests to look at how severe it is and what might be causing it. And the reason why what's causing it is important, because that dictates how you treat it, right? So that's what they've done. And what the no clear diagnosis means is that the liver blood test will still be abnormal, but all the other tests will be normal. Okay, so essentially, they will have found there's an abnormality, but we can't find why. Right now, in my usual, people who come to my clinic will know that I operate at a very high intellectual level, and so the analogy I use here is that we need the machines they have in Star Trek. So in Star Trek, you know, McCoy would wave this scanner and it would actually say the diagnosis on it. And all you need to do is to wave this at people and it would give you the diagnosis. And we need that, because that's what we don't have. Or we have a test that tell you what it isn't. And we don't have necessarily a machine that tells you what it is. So what do you do? So we'll wind forward a little bit. So what would you then do if you've got somebody who's got an abnormality and you can't find what it is. So there are three things you could do in this situation. So the first is to wait and see. So you've excluded all the important and dangerous things, okay? So what's left is likely to be not dangerous, and so you watch and see. So in liver disease, time is actually quite useful. So in 3 or 6 months' time, you know, is it still there? Now, why is that important? The commonest reason why people get abnormal liver blood tests, full stop, is after a viral infection. Non-specific viral infection, all those immune cells that the body doesn't want anymore after the infection all get broken down in the liver. They cause a bit of irritation. So remember what I said? You repeat the liver blood test, and you know, so often they're normal again. And that's because it was a self-limiting illness that has gone away, right? And any hepatologist will tell you that's the commonest thing that happens in this situation. You just check it again and see what happens. So that's possibility number one. Possibility number two is you play the percentages, okay? So as I said to you before, if it walks like a duck, has feathers and quacks, then it's probably a duck, right? Now, if you are 60 and female and your liver blood test abnormality is alkaline phosphatase and your mum had PBC, then the fact that you're AMA negative, you know, it's still quacking away, right? Mm-hmm. If your aunt had thyroid disease, it's less strongly associated, but it's still there. So the percentages are that you would, you know, think that, you know, what is the commonest reason to have a raised ALP phos in a 60-year-old woman in the UK? It's PBC. And then you've got some other information. So I would then play the percentages around it. I would never start treatment. I would discuss with people my thinking. The doctors who worry about, you know, people complaining and all of that, the antidote is be honest with people. Explain your thinking, explain the dilemma, explain why, what's going through your mind, and share the decision. I've never had a complaint. That's why. So I would put it to that. And I would say percentage wise, it's likely to be PBC. Now, if I start you on urso, then if the tests get back to normal, we've got the answer. Because remember, the final diagnostic test in liver disease is give a treatment that you think will treat the disease, and does it work? If you've got autoimmune hepatitis and you give somebody steroids, it will get better. And if somebody has abnormal liver blood tests and you give them steroids, it's not autoimmune hepatitis. So, you know, the response to treatment is a very important part of it all. Now, urso has no downside, as we said before. So there is no risk associated with giving somebody 2 months, 3 months of urso. You know, statistically, the commonest cause of liver disease in the population nowadays is obesity-related liver disease, MASLD or MAFLD or whatever they call it these days. So fatty liver disease, but that is treated by urso to some degree. So you're not going to make it worse with urso. So option 2 is play the percentages, okay? Yep. And that would, whether I did that or whether I suggested that, will be dictated largely by how abnormal the tests were. So how much time do I think I have to get this right? And then the third option is more investigations, and that normally means imaging of the bile duct and or a liver biopsy, okay? Now, in these situations, I almost never suggest doing a liver biopsy. Why? Because the likelihood of finding something that I will treat is very low indeed. I might find something, but a biopsy is quite an invasive way to say you don't need to worry about it, when statistically you don't need to worry about it. And so what you do when you do biopsies in these situations, you almost always find what's called non-specific hepatitis, and that's just this post-viral thing that's settling down. So normally in these situations, I reassure people that all the tests that matter are negative, and that rules out the things you really need to know about, like viral hepatitis and this and that. And I would give it a little bit more time. If somebody was very worried or their tests were getting worse, then biopsy is never the wrong thing to do in that situation, but I wouldn't go to it too early. But remember, those tests the 8 vials that are normal, because if they've done 9, you've got 1 that's still abnormal, the liver blood test. The other 8 are all normal, and that in itself is important information, because it tells you what you don't have. And in life, we have tests for the things you least want to have, if you know what I mean.
Yep. Okay, perfect. That's helpful. The other thing I would add is that if this is you, give us a call and let's see if we can help you ask some more specific questions of your clinician. Right, we've got a question in and around portal hypertension.
Yes.
Can this be linked with splenomegaly.
Splenomegaly.
Thank you. And varices.
Yes. So those three go together. They are
Yeah.
essentially the same thing. So portal hypertension, what is that? That is where, so the portal vein goes from your bowel to your liver. It takes the blood from your bowel all the way to your liver. And it's how nutrients get to the liver to be processed, right? So it's normal for it to carry the blood flow up, right? Now, when you get scarring in the liver, it doesn't have to be cirrhosis, but you get scarring in the liver, the blood flow through the liver is impaired. And so a bit like if you have roadworks, I told you I operate intellectual level. If you have roadworks on a road, the traffic backs up. And it's exactly the same with the portal vein, is that if you get narrowings of the blood vessels in the liver because you've got scarring, the pressure can build up, right? And that's what's called portal hypertension. It's hypertension, high blood pressure in the portal vein. So what are the effects of that? Well, if that then goes on, at the end of the portal vein is the spleen. And because the pressure goes up, the spleen blows up a little bit like a balloon, okay? So when you're a kid, you always fill balloons with water, and it's a really effective way of inflating a balloon. So the spleen grows because of the rise in pressure. And in between the spleen and the liver, the portal vein, you can have blood vessels branching from it that are old remnants of your in the uterus body circulation. So babies before they're born have actually quite a different circulation pattern to, after they're born, because of course their lungs don't need blood flow, do they? Their lungs aren't working, and so you don't have lung blood flow. So they have a whole different circulation pattern. And the first breath when they cry is a pressure change that then swaps that all around. But some of these vessels that shut down don't disappear, they're still there. And some of those connect up from the portal vein to up the esophagus and back to the heart. And if the pressure goes up in the portal vein, those can open up, and those are varices. So if you have PBC, then one of the things that goes through our mind is have you got the features of cirrhosis, pre-cirrhosis, fibrosis? Are you in that risk group of people that needs particular management? Okay. Now, it used to be more of a factor than it is now. This is to do with the treatments being available. We see it much less, but we will always still see it because, we'll see people who don't respond to treatment or who, present too late to have treatment. So it's always part of what we do. So how might we suspect that somebody's got portal hypertension? The last thing we want you to do is have a bleed from the varices. So we would look at your spleen size in the ultrasound. So that size of the spleen on the ultrasound is actually a good sign of portal hypertension. That's a good way to do it. But by far and away, the best way is FibroScan nowadays. So that's one of the main uses of FibroScan. So your FibroScan number tells you whether you're in the range where you might have that or where you don't have that. And, pretty much below about 12 to 15 indicates you won't have it. And above that, it's a possibility and you need to manage it. In the old days, we used to do telescope tests to diagnose the varices. And nowadays, we're more likely just to put people on beta blockers to reduce the risk of having a bleed. Okay, so that's a change in terms of the management. Now, varices are not a big issue in PBC. It's a good number of years since we had a bleed from any of our patients with this because of attention to detail. Going back to my comment about the politics of GPs managing it, this is what GPs really struggle with, is that they don't understand higher risk disease and how you need to manage it differently. So you do have to pay attention to this in the clinical setting. You can treat it, prevent it, manage it. The other thing to say is that everything is different. If you've got cirrhosis and PBC, everything's different. Treatments you can have are different. How you manage people are different. We actually see all the cirrhotic people in a special clinic because they need a different focus on them. So it isn't just a thing with your PBC. Do make sure that they're looking at all of those aspects. So it is a slightly different mindset when it comes to management. So in terms of risk, don't worry about it. It's well controlled and treated. It does say something about your PBC, and people need to be aware of it and think about it. And obviously, age comes into this. And anybody who had, was in their 30s with varices, with PBC, we will be talking about transplant and its potential role in the future, just so people are aware of all of that. So it does change. It changes the playing field a little bit.
Yeah. No, I get that. Okay, we've got a couple of questions in the room. So somebody is slightly concerned. I'll say slightly. So they've had some tests where their clinician called them in urgently for an MRI on Easter Monday. Now, they haven't since heard from the clinician, but obviously they're worried that they've been pulled in for an MRI without particularly knowing what it was for.
Yeah. Okay. So I'll take that in different bits, if you like. So
Yep.
MRI is what is an MRI? So MRI, magnetic resonance imaging. It's a good way of imaging the liver. It's a good way of imaging the bile duct. People might have heard of a test called an ERCP in the past, which was a telescope test. We used to investigate the bile duct with it. It was a pretty horrible test. And it's now been fully replaced by MRI. Very clever, very, very clever computing, looking at MRI images and calculating what the bile duct looks like. So it's a very standard procedure for us. So we do MRIs not often in PBC patients. We would usually do it if we were wondering whether somebody maybe had PSC, sclerosing cholangitis, rather than PBC, biliary cholangitis, because the MRI can often show particular things with it. So that would be a reason to do it. I have to say, in PBC land, we would almost never do an urgent MRI, because it's an exclusionary test for other things in case you've got it wrong. So if you've got barn door PBC with AMA and stuff like that, then it will be a completeness test rather than anything else. Now, so that's what MRI does. We do it to look at the bile duct, should that be important. It's relatively uncommon to find anything abnormal in that in PBC, and it's done usually for completeness sake. Now, I sense what's got you worried is that you were called directly to go in on Easter Monday to have an MRI scan. And it's impossible to say what that might mean, but what I can tell you is it may well mean not what you think it means, right? So normally MRI scans do not operate on an Easter Monday, okay? And you'll have heard this debate, back to politics, this debate about using NHS equipment. They will often open up additional slots to clear backlogs and things. So actually, you may well find when you're on your behalf, your clinician has ticked a box that says you're willing to go out of hours. So I know what you're worried about, but you may well find that this is purely pragmatic, that they've actually wanted to get some low risk people in who don't need ambulance transport and don't need two people to help them off the scanner, and they can go through 10 scans on an Easter Monday morning and reduce the wait time for other things. Now, they should have explained all that to you. If we'd have done that, I'd have been saying, look, don't worry about this. We've just got some slots. If it's okay, we can get it done nice and quickly. But they wouldn't want to do high risk ones. They wouldn't want to do problematic ones on a bank holiday. They'd want to do really simple ones where they could do them and get them out of the way. So I suspect there's poor communication here, and they should have told you what's going on. But I think you may well find that you're putting two and two together and making five, and it's just a practical way of getting a scan done because you're actually low risk rather than anything else. So I know why you're worried. I actually wouldn't be, but they should have explained what they're doing and why.
And do feel free to go back to your consultant and just ask the questions. We have literally no time left, but there are two really, really important questions I'm going to ask.
That's right.
Gastroenterologist wants to put me on 400 milligrams of bezafibrate as my ALP is raised to, I think it's 321, 327, something like that. Do you have any thoughts?
So 400 milligrams
bezafibrate.
Yeah. So obviously don't know the backstory about the PBC status, but an ALT of that level ALP, right?
Yeah.
Okay. So that's well in the non-response territory. So 230 is the cutoff. Above 300, if you're on URSO, you need second line therapy, right? So I think that's pretty straightforward. And then it comes down to a choice of which second line therapy to have. Personally, I wouldn't use bezafibrate as the first choice. I think we've moved on from that. We do have other and better options. The most obvious alternative is a thing called elafibranor. A drug called seladelpar is coming. Those are versions of bezafibrate that are properly approved and properly tested in PBC, whereas bezafibrate hasn't been. It's kind of a reuse of something, so there isn't quite as much evidence around it. So we wouldn't tend to use bezafibrate as an option because I think we've moved on beyond that. There's then obeticholic acid. The situation in which we do use bezafibrate is in combination with obeticholic acid, because that combination is very important. I would say, however, that in the audit, going back to the audit, I'll give you a figure. There are several figures that will worry people, but one of those figures that if you are out in the UK, sitting out there with non-response high-risk blood tests, you are 6 times as likely to have never had a second-line therapy than you are to have had a second-line therapy and it hasn't worked. So the problem here is not the right treatment versus the wrong treatment. It is no treatment versus treatment. Okay. So on that basis, it's a good thing they want you to go on to second line therapy. And I think therefore that's a perfectly reasonable thing to do. It's 90% of the right thing to do, but it's not 0%. And the thing we worry about is 0%. So I think it's a reasonable thing to do. However, unless you get a really good response to it, there are better options down the line, but you need to be in it to win it. And so therefore, I don't think that's an unreasonable thing to do. They're doing the right thinking. The dose is fine. That's the slow release version, which is the one we've got. If you've got itch as well, it's a good drug, as elafibranor is. You want to avoid obeticholic acid if you've got itch. So remember, the problem is not getting the right or the wrong treatment. It's getting not getting treatment. So you're better to start on that and review it. But remember, in this day and age, normal blood tests. And at 330, the chances of bezafibrate will normalize it are relatively low, so you may well need something else. Now, if you get on well with bezafibrate and it improves your blood test but doesn't normalize them, then what I would do is I would add in obeticholic acid. I would go onto the combination, because that really is the domestos that normalizes everybody. And I think therefore bezafibrate as a first step to combination therapy is logical, and pretty much, an outphos above 300, you may well end up on 3 agents rather than 2. Remember the goal. We're tightening up the bar here. We're raising the bar.
All right, thank you. Very, 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 very last question. If I was vegan or vegetarian, would I be worried that ursodeoxycholic acid is coming from bear bile farming?
You shouldn't be worried about that. It is made in a factory in Germany. It is synthesized from scratch. Okay, so the molecule, correct, was discovered in bear bile. Absolutely. It is part of the basis of Chinese traditional medicine in that regard. However, it stopped being produced in that way many, 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 many years ago. So it is purely synthetic as a drug. Okay, so it is constructed actually out of cholesterol. So you don't need to be worried about that at all. Of course, for those of you who've got experience of Latin, ursa is Latin for bear, so ursodeoxycholic acid, and I think the PBC Foundation used to have a polar bear as its logo. So we did kind of perpetuate the bear thing, but no bears are harmed in the making of ursodeoxycholic acid these days. So I can reassure you about that completely.
Wonderful. On that note, Dave,
but it's a reasonable thing, isn't it?
Yeah,
I mean, nobody wants to do that. I mean, it hasn't been. The days of urso being made in that way were long before it was ever used in PBC. We've only ever used it as a synthetic treatment. So please don't worry about that.
No, that's helpful.
Robert, you haven't commented on my picture in the background. Do you know what that is and why it's there?
Nope. Hit me.
That's Hadrian's Wall.
I did wonder.
I live about 2 miles north of Hadrian's Wall. Why is Hadrian's Wall there?
Are you on the good side, are you?
we're on the good side. We're on your side.
Yeah.
It's to keep out the anyway. But it's Hadrian's Wall. There you go.
Nice. All right. Perfect. Thank you. Okay.
Yeah. So please don't worry about Urso. It's absolutely, utterly synthetic. But it's a good question. Just out of interest, obeticholic acid is a bit like ursodeoxycholic acid. So it's a bile acid. Elafibranor, seladelpar, bezafibrate are totally synthetic, completely different types of molecules.
Yeah. There you go. So the rumors are true. If you're going to do a live Q&A session with Dave Jones, you will see a stony face.
Nice.
No,
what? A stony face. Dum, 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 ding.
We'll be here all week. Right, Dave, thank you so much. Good to see you, my friend. We'll speak soon.
Good as always. Thank you for the questions. Corkers as always. All right.
Take care. Bye all. Thank you.